Successful percutaneous coil embolization of symptomatic coronary artery fistula, a case report. A coronary artery fistula is an anomalous connection between a coronary artery and a heart chamber or a fragment of systemic or pulmonary circulation. These connections can be congenital, acquired, or iatrogenic in nature. Here, we present the case of a 36-year-old male with a past medical history of hypertension who presented to the hospital with a 2-week history of chest pressure, dyspnea, and palpitations. Symptoms were worse with exertion, but also present at rest and on relief with nitroglycerin. The initial assessment comprised an electrocardiogram which indicated a normal sinus rhythm with no signs of acute ischemic changes. Additionally, the exercise stress test, D-dimer, and troponin levels were all within normal limits. The echocardiogram showed an ejection fraction of 60 to 64% with no detectable structural abnormalities. Due to his persistent symptoms, the patient underwent a left heart catheterization, which revealed a large right coronary artery fistula. A coronary CT angiography demonstrated a fistulous connection between the RCA and the right ventricular outflow tract in the right ventricle, with no evidence of coronary stenosis or plaque. A fistula angioplasty was planned and performed using 11 coils to successfully close the superior, middle, and inferior branches in addition to the main fistula vessel. Post-operative echocardiogram and EKG were unchanged from prior with no new ischemic changes. The patient was started on dual antiplatelet therapy and recovered well. Upon follow-up, patient's chest pain was resolved. In the following images, you can see the coronary CT angiography showing the fistula, and in the image to your right, you can appreciate the 3D models created from the CCTA that helped us prepare prior to the intervention. Here, we can see the initial part of the intervention with the left heart catheterization demonstrating the fistula's large conus branch inserting into the right ventricle. To your right, you can see the guide wire being advanced across the conus lesion. Then, we can see the start of the coil deployment, and in the last image, we can see the results after the 11 coils were deployed. Finally, we can see the restoration of the flow into the RCA. The symptomatology, management, and outcomes of coronary artery fistulas are dependent on the size, location, and amount of blood being shunted. The majority of coronary artery fistulas originate in the RCA and insert into the right ventricle of the heart. In this case, the anomalous connection was between the right coronary artery and both the right ventricle and the right ventricular outflow tract, allowing shunting of blood from the left side to the right side of the heart. The shunting of blood can result in a coronary steal syndrome, resulting in myocardial ischemia and angina. Although most of the coronary artery fistulas remain asymptomatic, the most common complaint among symptomatic patients is dyspnea and chest pain, as in this patient's presentation. The American College of Cardiology and the American Heart Association recommend surgical closure for large symptomatic coronary artery fistulas and all coronary artery fistulas if myocardial ischemia, arrhythmia, unexplained ventricular systolic or diastolic dysfunction, or enlargement are present. The goal of the intervention is to seal the coronary artery fistula without compromising blood flow to any area of the heart. The modality of closure depends on the location, number of drainage sites, and cardiac comorbidities. Given the patient's symptomatic presentation, intervention and closure using coil embolization was recommended. Coronary artery fistulas are rare cardiac anomalies, but they should always be part of differential diagnosis of symptoms of chest pain and dyspnea, especially in patients without significant risk factors for acquired cardiac disease. Correction of coronary artery fistula is indicated if the patients are symptomatic or if other secondary complications develop. Thank you very much.